happy to introduce today Dr. Vissa, who's hematology oncology attending at Benioff Children's Hospital in Oakland. He's med-peds trained as well, and his current clinical research interests are around inherited hemoglobin disorders, so thalassemia, sickle cell. And so really excited to have you here and looking forward to learning more about thalassemia.
Thank you. And it's my pleasure to be here. Thanks so much for inviting me. And just a little background on sort of what I'm hoping to talk about today. We'll touch a little bit on thalassemia and sort of what that is and how it impacts individuals. But the crux of this, actually, I prepared this talk for a health equity series that was being done in our pediatric hematology and oncology department divisions, sort of shedding light on some of the more human aspects of the care that we deliver. And when the team asked sort of for ideas, I thought this is actually pretty fresh on my mind. And so I thought this would be an interesting topic to explore. And so it's going to be sort of a case-based discussion that's going to guide what I learned a lot on this topic. My goals are to really describe an increasingly common patient population in our general practice of refugees from Afghanistan. To learn about a really unfamiliar history, culture, and experience. I learned a lot about just this group of humans that I didn't know very much about. I'm going to introduce some principles of trauma-informed care for a refugee population, also not speaking as an expert, but speaking on what I've learned about it. And then I do want us to challenge some assumptions and some initial impressions that we might make when we're taking care of patients who are in circumstances either like this or sort of analogous to this. And I will just offer a disclaimer that I am by no means an expert in this. I really sought a lot of advice from people who are experts, especially Dr. Zareen Noor, who I think you guys are hearing from separately from this talk. I really learned a lot from just reading and watching videos and talking to people, but I have a lot more to learn. And I think I offer more food for thought than answers on a lot of the topics, really bringing up topics that we should be considering, but perhaps don't really have solutions for. And I know that I'm probably going to get things wrong. This is not intentional. And so any feedback or any sort of ideas or experiences that the group here has, I would love to hear as it pertains to the topics I'm talking about. So we'll start with a case, and of course this is as informal as you'd like it to be. Please interrupt. I'll try to check the chat or raise your hand or interrupt. So the case starts with us just having a usual day in our clinical practice, and the father of a patient that we don't know actually calls our thalassemia clinic, cold calls our clinic, requesting an appointment for his son, who he says is a 5-year-old with beta thalassemia major. He says his son needs a blood transfusion. He's advised that we'll probably need more information to appropriately navigate this referral, and tried to give him some resources to kind of go about the appropriate way to get into our clinic. Later that same day, he actually showed up at our clinic front desk, again, to request a blood transfusion for this son. And around that same time, the child's PCP did give us a call to discuss the case. So some of our initial impressions or assumptions that we could have made, and I encourage you to sort of think of what you're thinking in your minds as this situation comes up. The first thing was, wait, what? What is happening here? There's just this kid who came out of the blue, needs a transfusion. Who does this guy think he is? Just calling and showing up? Doesn't he realize there's a process for these things? You can't just barge in here demanding things. Of course, I wasn't on the receiving end of any of these phone calls, but I can certainly imagine that the perception of people could be that this was a demanding father, or this is a person who had sort of unreasonable expectations of our team. Case continued as we did end up receiving a proper referral from the PCP, and we got a little bit more information from the family. It turns out that he has a history of transfusion-dependent thalassemia, beta thalassemia, and the family moved to the Bay Area from Pakistan within the past week. He was last transfused about 3 weeks ago, and so he is due for a transfusion pretty soon. He was scheduled actually for an urgent clinic appointment that same week, as well as a transfusion in the infusion center within the same week, sort of speaking to just how much respect I have for our thalassemia team here in making things happen for the patients who need care. We got some additional history on our first visit. We learned that this child was born in Kabul, Afghanistan, and at around 3 months of age, he was noted to be pale, but otherwise growing and feeding well. At that time, his hemoglobin was noted to be 6.5, which is quite low, and he was started on a transfusion regimen. It was known that there was thalassemia in the family, and so this wasn't a very big surprise to them. We also learned that the family in the past couple of months had fled to Islamabad in Pakistan, where about a year before they arrived here, when the patient was 4 years old. He was transfused there for nearly a year before the family obtained a special immigrant visa, which I'll talk about a little bit later, also called an SIV, that allowed them to move to the United States. To our knowledge, he was updated on immunizations, but we did notice right off the bat that he had pretty poor dentition. So the first thing I was just, thinking about what this experience was for this family and this kid, I Googled some pictures of Afghan refugees and of people who had moved here from Afghanistan. These are the images that sort of show up right away in my mind. And so it sort of sets the stage for me to kind of put myself in the shoes of this family and sort of understand what the trauma and what the experience that they've had coming to this country may or may not have been like. Of course, this is a generalization and assumption, but these are images that really did kind of stick with me when it comes to just the initial impression I had about caring for this patient. You can see in this image, there's people boarded on an aircraft carrier with women, children, men, all tightly packed in, and it's not a short flight from Kabul to anywhere. So I assume that this is really a difficult experience, not to mention a lot of people who are racing to find a place on these because otherwise the consequence might be their demise. In terms of this child's transfusion history, he's had several transfusions and a couple of transfusion reactions, most of them with a fever. And so he's routinely given antipyretics before his transfusions. One thing we worry about a lot of patients who receive transfusions without a kind of very strict blood bank policy is the development of autoantibodies or alloantibodies against red cell antigens that make it difficult to match blood. Thankfully, to our knowledge, he had no alloantibodies. Another big consequence of chronic transfusions is iron overload, and he's been on a mix of different iron chelators since the age of 2. One, the staphylopram, is an oral chelator that he had access to for some period of time, and then deferoxamine is an infusion or subcutaneous. It's either subcutaneous or IV, but he ended up getting subcutaneous infusions a couple of times a month with a dosing based on ferritin levels. I won't go into too many details about sort of how we manage iron overload in our patients here in the US, but it's definitely on more sophisticated technology than ferritin levels alone. He was started on another formulation that we use commonly here called deferoxarox when he moved to Pakistan. But again, his chelation history was pretty inconsistent. And like I mentioned before, he has lots of dental caries. We spent a while, and we are lucky to have a social worker who helped us to really gather a lot of this information embedded within our clinic. We learned that the father worked as an interpreter for the US government in Afghanistan, and the mom worked as an engineer in urban planning. So these are pretty highly educated and pretty well-resourced individuals. They did live in Kabul, but they were targeted by the Taliban, as I'll discuss, that is not uncommon for people who worked with the US government. And it was really becoming increasingly difficult for them to ensure safe care of their child. So they made a very courageous decision leaving behind family to move to Pakistan and eventually come to the US. And they were supported by some international organizations, this one in particular called the International Rescue Committee. Really lucky for us is that both families speak fluent English and were able to communicate super effectively with kind of very high functioning medical literacy. They had one friend in the Bay Area, so they identified this as a reasonable place to move. And they were staying in Union City, but did tell us that they would be relocating to Pittsburgh, which is over in the East Bay. Parents identify as Muslim, but don't routinely attend mosque services. And we did note that, as is relatively common in Afghanistan, the parents are first cousins. And so this is a child of a consanguineous relationship. I lay all this out because I think that these details kind of help us to break down some of the biases or sort of assumptions we make about somebody coming to the US from Afghanistan. And I'll get into some of the biases or the assumptions that I might have made about learning that we were seeing a kid who was a refugee from Afghanistan. It became evident to me pretty quick right off the bat that I knew very, very little about Afghanistan. So I wanted to just take a few moments to learn about this, to kind of hear about this history, to learn about where these patients were coming from, acknowledging that I'm never going to be able to really know it, but that doesn't mean I can't start to learn. So I think it's easy for us who grew up, I grew up with 9/11 being just completely in the background of everything that shapes our policy against the Middle East and Central Asia. I think, do I describe Afghanistan as a country of war where women are oppressed and women are silenced and there's violence and guns and hardship as a constant in this country? Is this a country of war? Or is this a country of people, of culture, and of beauty? I just Googled Afghanistan beautiful, and these amazing images showed up of gorgeous mountains, happy children, beautiful mosques, and celebrations, as I would expect people anywhere to be experiencing. A little bit about the geography and just the geopolitics of Afghanistan. It's a landlocked country in Central Asia. It's adjacent to Pakistan and Iran, with a bunch of other neighboring countries around it, with several different ethnic groups. This was actually, I am embarrassed to say, was news to me that there's multiple ethnic groups, and it is absolutely not a homogeneous population. The largest ethnic group is the Pashtun group, followed by the Tajik, Hazara, and many other ethnic groups. But these all do have distinct ethnic identities, distinct cultural identities, and importantly, distinct languages. There's two official languages of Afghanistan. There's Pashto, of which there's two major dialects, and there's Dari, which is also called Afghan Farsi. And so people who speak Farsi from Iran or other parts of the Middle East can be understood to some extent by people from Afghanistan. Dari is taught in school, so that's sort of the national language, even though most people speak Pashto, especially those who've immigrated here. Lots and lots of other languages are spoken, and generally people who are SID holders, those who've worked with the US military, speak pretty good English. The predominant religion is Sunni Islam, but there's a lot of other religions that are prevalent depending on the cultural group. Important to know that the unified term of people from Afghanistan is actually Afghan or Afghan. And though many people may not individually identify as Afghan, they might identify with a more specific ethnic group, as you can see up top. Afghani, which I think is what I used to use to describe people from Afghanistan, is not a description of a people, it's a description of currency. So it's an Afghan, not an Afghan. There's a little map. I enjoy maps. I think that this is a good way to visualize what we're talking about, showing the different ethnic groups that are prevalent in Afghanistan. So the area in the south here is predominantly Pashtun. So you can see that's the most prevalent or kind of most widely geographically spread group. Kabul is right here, sort of spanning between the Pashtun and the Tajik, which is close to Tajikistan. And there's several other ethnic groups that are part of the makeup of Afghanistan. You'll also notice that this plays a big role in sort of how the history and evolution of Afghanistan evolved. Lots of languages. So again, Dari is the national language that's taught in school, but a good proportion of the population also speaks Pashto and other languages. And I hesitate to really call this anything, the national identity, because of course identity is individual and we can't describe its identity to anybody. But there are a couple of themes that sort of are prevalent when I'm reading a little bit about Afghanistan and the generalization of identity that might play a role in behaviors. So gender roles certainly play an important role. It tends to be a patriarchal society where the male figure is more of a dominant figure in households. And some, but not all, families may observe separation of sexes. One thing I did find to be pretty universal was respect for elders and a lot of honor. Honor being sort of pride in your family, pride in yourself, pride in your community. Part of that includes families sort of marrying amongst themselves. So consanguineous marriage is common, staying pretty private, having a lot of importance on politeness and hospitality, and really highlighting this importance of honor as part of the day-to-day life. There is, of course, significant differences between city and rural culture, and there's a lot of villages or more tribal areas that have unique cultural identities that I, of course, have no authority on commenting on. Some common misconceptions and importantly, some common assumptions that those of us in the West might feel or understand about Afghanistan. Importantly, this is not an Arab or Arabic ethnic identity or language. Arabic is much further west of Afghanistan, and this is a unique identity that's has very little to do with the Arab population. It's a misconception, as I mentioned, that they're ethnically, linguistically, and politically homogenous. There's a lot of heterogeneity in the makeup of Afghanistan. I think it's common to think of the burqa as a cultural dress of Afghanistan. It's actually a cultural dress of the Arab world, and there may be a different expectation for the dress of women in Afghanistan than what we sort of see traditionally in our media. It's also important to know that in our lifetime, Afghanistan has been in a perpetual state of war, but that's not really been the case for before our lifetime, and certainly is not the case in all parts of the country where people are really just trying to live their day-to-day lives. There is this misconception that everyone is strictly Muslim. That is also not necessarily the case. As in the case of our family, they identify as Muslim, but don't really attend mosque services, and it's not at the forefront of their day-to-day lives. And one, of course, important misconception is the misogynist values of the Taliban, especially with lack of a social mobility for women. This may to some extent be true in individual circumstances, but perhaps is not a blanket assumption that we can make about the entire country. So that's just a few things that I learned about Afghanistan, and now I want to take us back to our case. So the child arrived for their first transfusion in our infusion center with transportation arrived by our social worker. It was through Uber Health, and he was accompanied by both parents. On arrival, right away, the dad had a lot of questions about the transfusion process, about how much blood he was going to be given. And we usually do weight-based dosing of our blood products in order to achieve a specific transfusion post-hemoglobin goal to not only increase oxygen delivery, but to suppress the ineffective erythropoiesis that's driving the pathophysiology of thalassemia. So we ordered about 300 cc's of blood, but the dad was pretty adamant that he get no more than 250 cc's. And I say this at the risk of sounding judgmental, but he caused a little bit of a scene in the day hospital when this conflict arose of how much blood to give. We felt that 250 cc's was probably going to result in him needing a transfusion sooner than originally planned. So what are the assumptions and impressions that we have here? Gosh, why doesn't he trust us? Doesn't he know that we know what we're talking about? Is it rude for him to question our decisions? Are we just going to be having to deal with this like obstinate, rude, difficult person? Could this be a manifestation of a patriarchal society, or is there a control issue? Are we supposed to acquiesce to his demands because he's the head of the household? And of course, at the bottom of this is maybe this family has less education than we thought about appropriate thalassemia care. Maybe it's our job to teach them. Sort of funny that I'm describing a lot of like us being paternalistic when it comes to understanding the where this patient is coming from. And again, I guess we were wrong about how good their English is. They must not just understand. But then we dug a little bit more on what we learned is this family actually knew quite a lot about blood products and the standards of care about thalassemia. And they were really vigilant to make sure that their child was not over-transfused, which we certainly appreciate. They were actually familiar with blood products that used a different preservative than what we use in this country. They use something called CPD rather than what we use is CPDA. And CPD preserved blood has a higher hematocrit. So you actually do need less volume in order to achieve that same bump in hemoglobin. So the family was totally right. At that visit, while we were sort of sorting out the issue at hand, we agreed to transfuse the lower volume per their request, but did note that they probably would need a lower need to come in sooner, or that his hemoglobin might be lower and he might be symptomatic before his next visit. So I'm going to take us back a little bit to how we got here, and this is where I went into a deep rabbit hole of the history of Afghanistan and decided that I was going to give you a history lecture instead of a medicine lecture. So here we go. And I will describe this. I always think that preparing talks like this are interesting because I'm not reading PubMed or UpToDate. I'm reading like blogs and YouTube videos. And these two videos in particular from Vox were especially helpful for me to really get a little bit of the historical background without going into, reading textbooks, which I didn't have time for. So I put this timeline together, which hopefully I can go through with some ease. What I learned is that before the 1970s, Afghanistan was actually a really peaceful monarchy. Freedom was prevalent and the press had a lot of access to pretty much everything. It was interestingly from Europe to India was a stopping point on the hippie trail of the 1960s. And so there's lots of beautiful pictures of what we consider hippies to just stop in Afghanistan, appreciate the beauty, appreciate the culture, and be part of this very kind of free and liberated environment. In the 1970s, the monarchy was overthrown, and the government had made alliances with the Soviet Republic. And in 1979, the USSR actually occupied Afghanistan and took over the government. There were plenty of rural militia. They were kind of collectively called this group called the Mujahideen, who grew with support from other countries. So basically with the USSR occupation, countries like the UK, US, and other democratic nations tried to put in resources into these rural militia to try to oust the USSR. And they were actually successful in 1989. This was sort of a beacon for overcoming communism during the Cold War, where the Soviet forces were forced to retreat out of Afghanistan and the communist government fell. In 1992, this was essentially a victory for democracy. However, with the financial and military investment that was placed into Afghanistan in the 1980s, the withdrawal of that left really no unified government. And so this led in the 90s to a civil war between the Mujahideen groups and really no unified government um, to, to create some sort of governing body. Within this time, the group called the Taliban, which is actually translated to students in Pashto, began to form mostly in Kandahar, which is in the Pashtun region of Afghanistan. And these Taliban leaders were teaching strict Islam practices in madrasas that were widely trusted. The Taliban, I'll mention later, also was formed a lot from orphans of parents who were killed in a lot of these civil war battles. In 1996, the Taliban conquers Kabul and really starts to enforce strict laws. And this is where we really see a lot of the cultural images that we sort of know as prevalent today, where there was a lot of laws that were strictly enforced, targeted against women when it comes to them walking alone, seeking careers and other freedoms. As we all remember, in 2001, the 9/11 attacks on the US resulted in the US invading Afghanistan and led to the fall of the current Taliban government. Bin Laden and other Taliban leaders escaped to Pakistan, and the US occupied the country in order to try to rebuild it as a democracy with support from Mujahideen leaders around these rural areas. Lots of money was poured into trying to improve the infrastructure, to try to overcome corruption, to try to rebuild a democracy. However, in 2003, when the US invaded Iraq, a lot of that money was diverted and Afghanistan was sort of left without a solution. This led to the 20-year occupation of the US, where really not a lot of progress was being made. And during this time, the Taliban fighters did have an opportunity to rebuild an alliance with these rural areas. They were often funded by illegal opium trade and other corrupt practices, by taxing highways, etc. And they were able to establish sort of a stable but kind of fragmented government that the US was trying to address, mostly with drone attacks, but they didn't really stop the growth. And not to mention that these drone attacks to try to quell the growth of the Taliban actually might have fueled a little bit of their growth because of the distrust and the animosity against the US around the country. In 2020 and 2021, the US forces did eventually pull out, sort of acknowledging that the mission had failed. And Kabul was essentially right away taken over by the Taliban. And I just note that this is also during the COVID pandemic. And because of the rapid acute rise in Taliban rule, there was a mass deportation of Afghan refugees, both to the US as well as to neighboring states such as Pakistan. About 1.7 million Afghan refugees were deported, were traveled to Pakistan, and in 2023, most of those were actually were ordered to be deported from Pakistan. So that's sort of where we were left with our patient. I know that's like does not do justice at all to the kind of very complex geopolitical history of the last 50 years in Afghanistan, but it sort of helps me set the stage for sort of how we got to where we are. Here's what I learned about the Taliban. It's mostly made up of Pashtun individuals who practice a very literal interpretation of Sunni Orthodox Quranic texts. I don't really understand this, but the Taliban ideology really can't exist without war. That war is sort of a necessary component of the progress for the Taliban. Recruitment for the Taliban, and as I mentioned, this is students, were targeted at orphans who lost their parents during Soviet occupation. So these are people who already were harboring some resentments against the government regimes, and additional recruitment was done by people who were affected by future wars, especially the US drone warfare. Women were especially targeted by some of the literal Quranic interpretations for oppression. And to kind of come to where we step in, healthcare under the Taliban was I don't think it's a surprise to anyone, was pretty bad. There's been significant decrease in the quality and access to healthcare since 2002 when the U.S. occupied. And although there was some transient increase in resources in national and international support, that really did, dwindle over time. It's gone into even more crisis since the fall of the government in 2021. About 90% of healthcare facilities have closed. And these are probably slightly old statistics. I worry that they're even worse now, but there's about 5 nurses and midwives and 2-ish physicians per 10,000 Afghan people. And the global average is much higher than that, about 13 to 20 physicians per 10,000 people. Children in Afghanistan were particularly at risk for mortality due to malnutrition and lack of access to water, infectious diseases, etc. How am I doing on time? You can imagine, I mean, we feel sometimes under-resourced working in our communities, but these clinic staff often have to work without salaries or supplies. Sometimes patients actually have to purchase their own supplies and medications in order to receive care. And one statistic that I thought was sort of shocking is that more than 70% of the population of Afghanistan had to travel more than 10 kilometers to access care. And of course, that's not to say that this is quality care. This is just any care. Of course, hard to say that these issues were not exacerbated by the COVID-19 pandemic. Of course they were. And most of these people don't receive any preventive care. This is all sort of reactionary care. Lots of other challenges that do impact the ability to receive care. First is natural disasters. So there is significant drought as well as earthquakes. Crime is really high in some of these places, including kidnappings, theft. COVID-19 is, needless to say, a complication. Poverty, illiteracy, and sanitation, clean water all play a role in the health milieu of people in Afghanistan who are under this Taliban regime. So finally, let's talk a little bit about thalassemia. And just for those of you who haven't seen too much thalassemia, hey, come see us. We love to have learners with us, and we would be delighted to teach you more on one-on-one in a patient care experience. But just to summarize a little bit about thalassemia, it is an inherited disorder that affects the quantity of either the alpha or beta globin subunits of hemoglobin. And so a deficiency of one actually leads to the excess of the other, which can contribute to the pathophysiology. It has a really variable phenotype, and it depends on the genotype, and it can range from asymptomatic, people who have never needed transfusions, never needed any interventions, to those who are transfusion dependent. There's a lot of intermediary steps in between where patients may require some transfusions or may be symptomatic from anemia that we have to be careful of. Of course, for patients who do rely on transfusions, they require a safe supply of both healthy and compatible blood products to make sure that they're actually safely transfused. And iron overload from transfusions can cause organ damage, so we want to monitor heart, liver, endocrine organs. These are things that we sort of take for granted for our patients who have easy access to blood transfusions in this country. Patients who aren't reliant on transfusions, they're non-transfusion dependent, they may have other complications like endocrinopathies, heart dysfunction, extramedullary hematopoiesis, and other things that may require some intervention. So just because you're not transfused doesn't necessarily mean that your disease is mild. Our building is shaking, so don't be alarmed if I'm a little bit anxious here. We have really very poor estimates of the prevalence of beta thalassemia or any thalassemia in Afghanistan. The best estimates place it at around 1 to 1.5 million individuals who are carriers for beta thalassemia, meaning that they have at least one abnormal gene and have a potential to get onto their children. In this country, we do a lot of prenatal and antenatal testing, as well as newborn screening to assess for risk for thalassemia, but it's either unavailable or unaffordable for most people. Most children are not brought to care until after the onset of manifestations of disease, like our patient who presented with severe pallor and fatigue. And interestingly, females may be even more delayed because in some areas it's necessary for girls and women to be accompanied to any visits by their husband or male relative who are often unavailable because they need to participate in work or participate in wartime efforts. And I hesitate to say this, but it's also possible that it's just not important for the females to be receiving medical care. You've all probably seen a map like this showing sort of the prevalence of hemoglobinopathies across the world. You'll see this kind of band here. This is our belt of thalassemia. This correlates very specifically with areas that have high prevalence of malaria because thalassemia and sickle cell mutations, any really Any red cell mutations typically have evolved as a protection mechanism against malaria. But Afghanistan right here falls sort of directly in that belt, especially in this Pashtun region in the south. And this, obviously isn't a discrete line. The line can blend a little bit. Blood donation in Afghanistan. Like I mentioned, the patients who require transfusions really rely on a safe and healthy blood pool that has a good matching to ensure no antibodies or transfusion reactions occur. What I learned is most blood that's used is actually donated by family members, either directly to the patients or used to replace the blood that was used by the patient. For reasons that are becoming more evident to me now, the donor pool is almost exclusively male, and families often have to procure their own blood, either through arrangements with other family members or their own blood. There really isn't any routine screening for infections like we do here, such as hepatitis, HIV, and HSV. And there's really limited availability for cross-matching to ensure that the compatibility of the blood. So back to our case, as expected, about 2 weeks after his first transfusion, and of course on a Friday afternoon, our clinic receives a call that the child looks listless and pale, and the family thinks he would benefit from a transfusion. We offered social work support to bring the kid to the ER for labs and likely admission, but for reasons that were not clear to us at the time, the family declined. We had made a plan for the child to be brought in over the weekend for likely transfusions, and there's lots of challenges with transportation, bed availability that we needed to sort through. So here, oh, the shaking stopped, thank goodness. Here we're thinking, oh my gosh, it's Friday. Why do we have to accommodate all these demands? Why couldn't they just, participate in this plan that we set forward, which is already pretty difficult for us to put together? It's not our job to find transportation. Our hospital can't cover an Uber all the way from Pittsburgh. That's such a financial burden. And I'm sure there's lots of other assumptions on a Friday afternoon that we probably made. So this is where I wanted to transition a little bit into sort of the experience that our patients may have endured coming to this country. This is a picture of Holman Air Force Base, also called Aman Omid Village, which means peace and hope. And when there was a mass exodus of Afghan refugees in 2022, this was one of the places that a lot of them came to in New Mexico. You can see that looks like tent villages, it looks like very temporary housing, and it's in the middle of the desert. And so can't imagine that this was an extraordinarily comfortable place to go, but thousands of individuals ended up coming here after escaping Afghanistan. There are a couple of definitions I wanted to just discuss here. One is the difference between a refugee and an asylum seeker. And I'm so sorry, let me just respond to this page really quickly. But these are the specific definitions. A refugee is someone who, owing to the well-founded fear of being persecuted for reasons of race, religion, nationality, membership of a particular social group or political opinion, is outside the country of his nationality and is unable to, or owing to such fear, is unwilling to avail himself of the protection of that country. Sneeze, it's gone. This is in contrast to an asylum seeker, who is an individual who does not meet the legal definition of a refugee, but who applies for asylum or refugee status after they're already present in the US or at the port of entry. Asylum applicants can have any or no immigration status when they apply, and asylum status can be granted either by this asylum officer or by an immigration judge within the US Department of Justice. So I don't think we need to get into the weeds about this, but there's just specific definitions when we're talking about refugee versus asylum seeker. There's this other category of individuals who hold something called a special immigrant visa. And this is, I think, pretty specific to Afghanistan. SIV holders were Afghans who worked alongside American forces. These are people who usually worked as interpreters or other sort of local liaisons to the American forces. And you can imagine that they may have incurred significant risk as a result. Most SIV holders and their families are considered traitors and are vulnerable to the Taliban. And many of them are actually targeted for violence. You can imagine that translators perhaps might be at risk for torture to obtain information about the US intentions. And so a lot of our patients have either been at risk for or have experienced direct violence from the Taliban. They have a history of probably needing to withhold information, which is troublesome. And these people are actually allowed to enter the US immediately without entering through a military base. And they are considered lawful permanent residents because of the special immigrant visa. Unfortunately, the SIV status was not designed for a mass refugee crisis. And so upon entry into this country, they may or may not actually have all the resources available. These are also probably older statistics, but as of 2022, there was about 70,000 Afghan refugees who arrived as part of this Department of Homeland Security program called Operation Allies Welcome. There's this other group of people called humanitarian parolees, who are refugees that work with NGOs after entering through these humanitarian camps, like the Abid Oman village, to establish permanent housing. SIV holders, like our patient, actually enter the country directly, but perhaps may not have direct access to these NGOs or other resources to help navigate that transition. What's relevant to us here in the Bay Area is that Fremont, California actually probably has one of the largest Afghan populations in the US. Some people refer to it as Little Kabul. And so many families actually have moved to the Bay Area because they may or may not have somebody who they know, or at least a community that they can be a part of in this area. And a lot of our families do have family remaining in Afghanistan under the Taliban rule. So they live with this constant fear despite perhaps escaping the danger for themselves. The resettlement of refugees really does depend on immigration status. So whether you're a parolee, SIV holder, SIV applicant, or an asylee, there may be different access to benefits. And this could include medical exam and screening, vaccinations, and benefits from the Office of Relocation. I think this is really cool that people who hold an SIV have immediate access to cash assistance and medical aid, especially if they're not eligible for Medicaid, and many long-term benefits, including employment assistance and other specialized training programs, mentoring programs, and community programs. So there are a lot of resources available, but again, none of these were designed for a mass refugee crisis. These are designed for individuals coming through the system and being and relocating to the US. In terms of the medicine associated with this, a lot of patients from Afghanistan should really be assessed for chronic medical conditions that's pertinent to us are anemia, iron deficiency, and beta thalassemia. And because of the high prevalence in contiguous marriages, genetic disorders such as thalassemia should also be considered. Refugees may or may not be familiar with the insurance system and other common aspects of US healthcare, like how to find a PCP and getting referrals, et cetera. Not to mention the stress associated with just having gone through everything they've gone through. I mentioned that there's pretty low literacy rates, both in men and women in Afghanistan. And so that might also impact the just interactions between medical teams, resources, and the families. And all of this takes time. Relocation, work permits, insurance, all of these take a lot of time and a lot of support to go through. This is just an interesting image I found looking at the prevalence of refugee immigration. In the 80s and 90s, there were substantial refugee immigration due to the respective occupations in those times of the Soviet or of the Taliban. But in 2022, there was just a dramatic increase in the number of Afghan immigrants who lived in this country, most likely due to the acute refugee crisis in 2022 after the Taliban took over the government. I know this is too small to read, but I just wanted to mention that there's a high prevalence of infectious diseases as well, like worm infections, lead levels. Sorry, that's not an infectious disease. Latent TB, hepatitis B, and lots of other medical complications that are informing, especially children's healthcare in this country. And when it comes to the patients that we're seeing in our thalassemia clinic, if under-transfused because of access or because of unsafe blood supply, some of these patients might have poor growth, they might have skeletal changes, they might have something called extramedullary hematopoiesis, where in an effort to produce new blood without the appropriate resources, a lot of the other bones in the body, such as the vertebrae, the skull, and the pelvis might expand beyond their current space. Alloimmunization or antibody formation against unmatched blood products does limit and restrict the availability of blood products, and then potentially nosocomial infections from infected transfused blood. About 4.5% of blood products from Afghanistan might be infected with HIV, Hep C, Hep B, or syphilis. Iron overload, of course, might have been undertreated if patients didn't have access to the right both diagnostic and treatment strategies. So back to our case, things were going okay, but a few weeks later, we were called to the day hospital in Oakland because the father had stopped the IV pump administering blood. Oh gosh, here we go again. Oh man, he can't do that. How are we going to set boundaries? Doesn't he want his son to get good care? Why doesn't he trust us? These are perhaps the assumptions that I had walking over to the day hospital to confront this dad and find out what was happening. By this time, I should have known better that this dad actually knew what he was talking about. This patient has type A positive blood, and the dad noticed that the blood hanging from the IV pole was O positive, so he was concerned for a type mismatch. In Afghanistan, this father arranged direct donation from another family member in exchange for his own blood. So this dad actually donated his own blood for that family's child to receive safe transfusions. So he was directly responsible for the supply and the quality of blood for his son. He was also responsible for procuring the equipment, so IVs, IV access, all of the tubing for the child's transfusions. So learning about this, we really, had to take a step back, be patient, explain to the dad that O positive blood was compatible with A positive blood, and that we have really strict protocols to ensure safe and compatible transfusion, which he acknowledged and was appreciative of. So I think this leads to maybe the final segment of this talk, which is just thinking briefly about trauma-informed care for refugees. Again, this is a topic that I don't have as much experience in as other people, but I'll just share with you what I learned. I think just coming to terms with how to care for these patients really forces us to have a recognition and response to the impact of traumatic stress as it pertains to our patients. It really, really, really calls upon use of all the resources we have available to us, social work, psychology, community resources, cultural resources, religious resources, to both maximize the physical and psychological safety in order to facilitate recovery. One survey from the EU found that about 85% of Afghans have witnessed a traumatic event, and this includes children. And I like this image as showing some of the key principles to trauma-informed care, which might seem sort of obvious to us, but thinking about them more specifically probably does help create a framework of ensuring that we're addressing safety, trustworthiness and transparency, peer support and mutual self-help, collaboration and mutuality, empowerment, voice and choice, and cultural, historical, and gender issues. There's probably many more layered in amongst those, but those are the key core principles that have been described. There's some specifics to refugee stress that I wanted to mention. The first is traumatic stress, of course, witnessing or being a part of war, violence, poverty, displacement, and migration. All like those images I showed at the very beginning of even getting on an airplane packed with people and traveling for what I'm guessing is a many, many hour flight can be very traumatic. Resettlement, showing up here, stepping off the plane doesn't solve your trauma. Knowing how to continue living is really, really difficult. So the financial stress, employment, housing, community support, families who are just trying to take care of each other can be really difficult. Acculturation stress, they might not know the language, they might not have an identity. There might be generational differences between younger generations and older generations who have different expectations for what relocation looks like and what acculturation looks like. And universally, I've witnessed isolation being a huge impact on the experience of people who have traveled here as refugees. I took these slides from Dr. Noor, who I think did a really wonderful job of explaining them to me, just to sort of visualize the components of trauma experienced by refugees. So it's in these three phases, and of course, there's a lot of overlap between them. In this pre-flight phase, this is the trauma experience before moving, before relocation. This includes things like violence, ethnic and political persecution, torture, and lack of protection or abandonment, and whatever else is associated with living in wartime in a country like Afghanistan under Taliban rule. Next is actually the flight and evacuation, actually leaving. So during this time, there might be a lot of experience of violence and physical injury. There might be extortion. There might be life in holding centers, even pleasant ones like the camp in New Mexico. There's absolutely going to be separation from family and community, lots of fooding and housing insecurity, and potentially a lack of safety, and illness and lack of care just because of the volume. And then resettlement, the trauma after you've actually moved, language, community isolation, loss of community, poverty, financial strain. I have a family that I take care of for iron deficiency. It's like, it's not even thalassemia. And the dad is so stressed out about his lack of a driver's license that makes it difficult for him to get a job, that he's developing gastric ulcers that are bleeding. And he's actually needed to be transfused a couple of times because of bleeding gastric ulcers. Discrimination, racism, xenophobia. It's still not easy to be someone of Middle Eastern descent in this country. Um, Generational tensions, unmet expectations, and the list goes on about things that continue to cause trauma for patients who have already escaped trauma. Of course, our hope is for things to be better, but we can't assume that just because someone has left a traumatic environment that the trauma is done. And we have to listen to this, right? And we get to hear these stories and we get to participate in the healing, but this can be really stressful for us as well. So secondary traumatic stress is definitely something I want to just briefly mention. I cannot tell you how to deal with this effectively because I struggle with it myself. But listening to the stress of others can really impact the whole care team and every other resource that's available to the patients. And so we have to be aware that in order for us to be providing safe and trauma-informed care for the patients, we have to acknowledge the impact it has on us as well and seek the support that we need in order to provide that care moving forward. So a couple of just principles that I've sort of summarized here in terms of trauma-informed care for Afghan refugees. One is to be curious but respectful. Make sure we're asking the right questions so that we are expressing our care and commitment to their recovery and to their ongoing health, but also respecting the boundaries and making sure we're not pushing patients beyond what they're ready to talk about. Though many of our patients do come here with a pretty good comprehension and vocabulary in English, using interpreters is incredibly important, not just for clarity and to make sure that we're actually getting accurate information, but also to acknowledge that the language barrier and the cultural barriers are something that I don't expect them to rise to my level, that I'm going to meet them where they are as much as I can. Some of our patients may actually agree with you just because they're trying to be polite. As I mentioned, that's one of the key sort of elements to the national identity in Afghanistan is agreeableness and politeness. So we really have to ensure understanding and not take a yes as the truth, but really dive in and make sure that our patients are engaged in their care the way that we believe that they are. Having cultural humility, I think this is not a concept that is foreign to anyone here, to acknowledge that I can read all I want, I can watch all the Vox videos I want, I can't live in this person's life, and I don't know what their experience was. So being curious and being humble that I always have something to learn about their experience is important. And then, of course, respect and collaboration for the learned experience of patients and families, really working with them, not for them. This is way too much, but I can leave this as a resource of just a few ways to give culturally informed and trauma-informed care. One is developing trust and connection. A couple of ways to just acknowledge that I have a different culture, but I will do my best to meet the expectations you have from your culture. Things that are pretty bonehead to me, honestly. Be respectful, be compassionate. I'll share these slides with you so that you can take a look at them, but I think this is a good slide to sort of specific to the Afghan population, understand a little bit more about sort of how my behavior can change in order to strengthen our relationships. So just wrapping up a little in the last few minutes, back to our case. What we really needed to do as a team was come together, listen, be curious, and recognize what this family's strengths were. We recognized that their English was outstanding, and that was a real asset and real gift to us in order to be able to communicate with them in a way that was really meeting our strengths. This is really hard for us, right? And if we add a language barrier, of course, we're going to still do it, but having a language barrier eliminated really made a huge difference for this family, and we needed to acknowledge that as a strength and something that they bring to the table that we didn't have to bring to the table. Their education was also a key strength, and not to mention, this is a delightful family. They're so kind and so lovely, and obviously had so much love for their child. And they were really hopeful. This was not a family who was expecting to fail. They really wanted to do well, and they really wanted to succeed in this country, and had so much hope despite how much their they'd been through in their lives. At our first encounter, we learned that they were already enrolled in Medi-Cal, CalFresh, and Cash Aid. And so these are certainly not people who are waiting for things to be handed to them. They were working hard and they were trying hard and they were absolutely doing their best. And, I haven't mentioned this child very much, but despite all this hardship, our patient is just this sweet, happy, loving, adorable little kid who's got terrible teeth, but the rest of him is so, so, so good. Our team has worked hard to listen, to be curious about the experiences that have shaped their behavior, and to try to check our assumptions and initial impressions and really put it in the context of where they might be coming from. We need to provide ongoing education and really be patient about healthcare systems here, not draw conclusions that they are impatient or that they don't know what they're talking about, but that maybe we need to be patient with them in a different way than we are with other patients. We realize that we're navigating challenges of connecting this patient with primary care, dental care, school, and that takes time. We're not going to achieve that right away. And we really want to support their connections with other families. This is, of course, not our only family who's immigrated here under difficult circumstances. And so we do have other families that we can connect them to and other resources that we can connect them to that we can learn from really all of the people that we take care of. And to challenge some of our assumptions, I think what we recognize in the examples that I gave throughout this lecture is that these parents' behaviors were almost always informed by an experience they have of constantly fighting for safe and necessary care to keep their child alive. Nothing that they were expressing had to do with their belief that they were better than anyone or that they knew something that we didn't know. It was because of because of their lived experience and what they needed to do to make sure their child was safe. Their knowledge about their child and health condition is so valuable, and we can't assume that we know better than they do. I learned that parents are often willing to do whatever it takes, even when it's dangerous, to ensure that their child receives safe and urgent care. And for a family that had to fight so hard for so long, maybe we need to find a little bit of patience, a little more than usual, to facilitate that transition to a new way of life. So I really enjoyed thinking about this case and understanding a little bit more about my approach to taking care of someone with this kind of trauma, and hopefully apply it to really all the patients I take care of. Everyone comes to the table with something that's an experience, with lots of experiences that I don't know and I don't understand. So with that, I leave you with this beautiful photograph of the city of Kabul, and welcome any questions. I have a lot of resources here. I could not have, none of this was off the top of my head. This is all from what I learned putting this talk together. So I'd be happy to take some questions if there are any.
Thank you so much. That was amazing. It's like a tour de force. It was like a structural, social, historical analysis of a family that, reaches that we might see for a snapshot in time, and also puts a whole new lens on these kind of like, we label families or patients as difficult, and they're not. There's so much more in there, and so much of both their past experiences and ours that we're bringing to that situation. I'll open it up to questions if people want to come off mute and ask a question, or if they feel more comfortable putting it in the chat.
Question one, a thing that's come up multiple times for me with families culturally, where like the father speaks English but the mother doesn't, and they like decline interpreters and like choose to kind of interpret through the father, and sometimes that feels challenging depending on the like conversation you're having and how much is getting interpreted, but also wanting to respect their family like culturally. So it's kind of how you navigate that.
Yeah, I wish I had a good answer to that, or like a real sort of universal truth. I think, Erin, you're totally right that it does feel really uncomfortable, but I think that that's a situation in which maybe I need to prioritize what matters to the family and what matters right now to this child. And I don't know, I think as you get to know a family and as you sort of see them over time, you probably will make observations about whether it's how important it is in the care of this child to engage both parents without an interpreter, or sorry, with an interpreter, versus trusting that the information is being passed along. I actually think it's really important for me to check my assumption about, maybe the child's mother isn't supposed to be making decisions about this family. And sure, we have our American ideals about equality, but it's not really my place to impose that on somebody else's family. I'll offer it, of course. I'm never gonna like make my own assumption that the mother doesn't want to be involved in the discussion, but I sometimes pick my battles for that, at least at first.
We have put a link to a survey in the chat. This is for a very brief survey, 3 questions. We appreciate your feedback. If you all wouldn't mind just taking a minute to fill that out. And would you be willing to share those links that you showed on the last slide? We can distribute them to the residents and those who attended. And if you have any other suggestions for, I really like Jasmine had a question on one of our previous sessions, like what do you recommend that we read in this space so that we can be better providers?
Gosh, there's the slides at the slide at the end did have a lot of links that is actually Dr. Noor had sent me. I sent her a desperate plea for resources when I was putting this together, and she was amazing. So first of all, go ask Zareen if you have questions, because she knows so much more and has so much, like, just such rich experience. So I really rely on the humans that we have around us. We're so lucky to be working in this place that has that. Would you want me to send the whole slide deck or just that last slide? I'm happy to share all of it.
Yeah, especially the last slide. What we can do is we can post it on our wiki so that people can refer to it.
Sure, yeah. There's a couple of public health organizations. I think Minnesota has a pretty large refugee population from Somalia, and so I think they've adapted that for Afghan refugees as well. And so I think I learned a lot from the Department of Public Health from Minnesota. Yeah, why don't I just send the whole slide deck to you, and you can pull out what you need to. That slide at the end that had sort of that colorful graph, I think, is probably a really good resource to have kind of up in clinic. If you are seeing a patient who has immigrated here, whether they're a refugee or not, they've seen violence. So
okay, well, thank you so much for your time. I really appreciate it. It's the case-based approach to this was a really nice way to cover a lot of topics. Thank you very much.
I really appreciate the opportunity, and this was enlightening for me to put together. So thanks for the opportunity. Take care, everybody.